Hello from Madrid. I'm Alfonso Jurado, one of the staff of the Interventional Cardiology Department here in La Paz University Hospital. And it's our pleasure to participate in the Mainstream program. It's an honor for all of us and to show our first live case in the program. I'm going to introduce you the people who is working in the cath lab. The procedure is going to be performed by Dr. Moreno, Dr. Galeote. We have our nurses, Chus, Ali, Sofia, and also we have the support of the anesthesiology team and a lot of people working in the backstage to make this possible. Thank you for all of them. And now I'm going to give the word to Silvio Vera, one of our fellows, to present the case.
Okay. Hi, everyone. This is our first case. This is a 89-year-old woman with history of hypertension, atrial fibrillation, paroxysmal atrial fibrillation, and severe aortic stenosis with a mean reading of 49 millimeters of mercury, preserved ejection fraction, and pretty bad functional class, shown of red, 2-3 functional class, and also angina. As you can see, no high risk score. The patient is in sinus rhythms, and she has left bundle branch. And this is the TAVI study, coronary and femoral angiogram, no coronary artery lesions. We like to see in the femoral angiogram where the bifurcation is. Of course, we have the CT scan information, and we have an annulus with a 26 millimeter, an area of 526 millimeters square. We don't have so much calcification according to the Agatston. And we don't have problem with the height of the osteocoronary. And this is the scan of the femoral artery, and we have the good diameter with 7 millimeter of diameter in the common femoral artery. And what is the plan? We're going to put a TAVI device, in this case a MYVAL, that is a balloon expandable device. This is the feeders. And according to the size matrix and according to the information of our patient, we have to put a 26 millimeter device. And this is the whole plan. As I said before, a MYVAL balloon expandable valve with a predilation with a 23 millimeters balloon, no coronary projections. The axis is femoral echo-guided, and the femoral bay to the transitory pacemaker. And we are going to use a collagen-based vascular closure device, in this case, Amanda. Okay, and I give the word to Dr. Moreno and the team.
Dr. Moreno, who is going to explain us all the things they have done till now and the plan for the complete procedure. Dr. Moreno.
Hello, everybody. Thank you, Mainstream, for having considered us to participate in this excellent project, and thank you very much to all of you that are now connected. We have up to now we are implanting the valve through the right femoral artery. We have punctioned the left femoral artery with echo. We have punctioned the right femoral artery with contrast injection. I think we can see one of the images we have here that shows the punction.
You have here the...
Yeah, you can see it now. We usually, I know that every center is different, but our practice is using a contralateral wire to protect in case we have any complication. The wire we use is the steel core from Abbott. In some cases, we use the contralateral artery, femoral artery. In other cases, we use the radial artery to support and to use the wire. But in this case, we have used both femoral arteries. What we have done up to now is to select the projection, the view. The view we are going to use is 25 degrees, I think, left, 1 or 2 degrees caudal. At the beginning, we had some difficulties identifying the anatomy, but it was only that a frequent problem that the pigtail is too deep and that don't allow us to clearly see the right femoral, the right sinus. But in this case, you can see how this is the right projection. What we have done is we have crossed with a Terumo wire to the left ventricle. We have interchange with a 35 wire, and we are going now to use the Safari wire to support the balloon and the valve.
This is a small Safari wire.
This is a small Safari wire, as Guillermo Galeote says. In this case, we are going to implant, as Silvio told you, a balloon expandable valve. In our center, we use both self-expandables and balloon expandable valves, and among the balloon expandable valves, we use both the Sapien and also the MYVAL. The MYVAL has some differences. It's very similar, but have some differences in comparison with the Edwards valve. One difference is that the sheath that is being used is a 14 sheath for all the sizes. You know that in the Sapien valve, if you are going to implant a 29, you need a 16. Here we use a 14 expandable sheath for all the sizes. Other difference is that the valve, once it's crimped outside of the patient, but is mounted once you introduce the valve in the anatomy of the patient. So that means that if you need to take the valve out, you can do it because the valve can be retrieved by the sheath. And now we are going. Yeah, I think we have some message here.
I don't have them. Sorry.
Well, you know that you can predilate or not predilate the balloon expandable valve. The company in this case usually recommends to predilate still the valve, but we have done a case before this patient in which we didn't predilate. But in this case, it is a very calcified valve, so we have decided to predilate the valve.
It's 23 at most.
It's a 23 balloon. It may be a relatively small balloon for this size. I think the annulus was 25.9. It is a small balloon according to this annulus, but just in case, because it's a very calcified valve, but we are going to predilate with this balloon. Okay, el paramarcasos es.
¿Esto cómo era? ¿Entre los dos o entre...?
Creo que es aquí, sí.
Un momentito, a ver. Ya vale.
Pacemaker, marcapasos a 180, por favor. We are going to do a rapid pacing.
Ya.
Vale, fuera marcapasos. Okay, I think the valve have been adequately dilated. One important thing in this valve, in the MYVAL, is that once you have predilated, or even if you don't predilate, before introducing the valve to the sheath, through the sheath, you have to use again the dilator to facilitate the advancement of the valve through the sheath. You are going to see it now. So if you were going to implant an Edwards valve, you could introduce the MYVAL device inside the sheath without any problem, but now in this case we are going to see how to facilitate the advancement of the valve through the sheath. We are going to introduce the dilator again.
Never forget this step because it's very important.
You have seen also that we are using a temporary pacemaker. You know that many physicians, many centers use the Safari or the wire that is inside the ventricle as a pacemaker. We do it also in some cases, but when we implant a balloon expandable valve, we prefer to use always a pacemaker because we think that it is more safe and we don't want to have any surprise. You see that it is hard to introduce and to take out the dilator. So other difference between this valve and the Sapien is that this valve has available up to 32 diameter. This valve also has intermediate sizes. In fact,
Para
in
arriba
this patient,
la marca.
the 27.5 could have been more appropriate, but as there is a severe classification in the CT scan, we decided to use a 26 abdominal inflation, and if the patient has an important perivalvular regurgitation after implantation, we would post-dilate with a larger balloon. You see how we are. La guía suelta.
Sí, está suelta.
Pasa. Está difícil, ¿eh?
Tiene...
Hemos introducido el dilatador adecuado, ¿verdad?
Vicente, ¿el dilatador era el del tamaño adecuado? Si tienes algún problema, lo volvemos a meter. Lo volvemos... No, pero ya...
Aquí está, sí.
No, está dentro. Lo que pasa es que se ve muy mal con esto. No sé por qué. Lo tienes a tope, ¿no?
Sí.
I think the diameter of the
Femoral artery.
iliac and femoral artery is limit in this case because it's a woman, a small woman. Sorry.
Okay. Now we can begin to rotate this.
Yes.
Yeah, to facilitate advancement of the valve through the.
This is like the Edwards valve, similar.
A tope, ¿verdad?
Yes.
Vale.
But
You can see that we don't need to mount the valve inside the balloon in the abdominal aorta because the valve is promounted. So in comparison with the Edwards valve, that you need to mount the valve inside in the abdominal aorta. Dame un test, por favor. Sí. The position of the valve is, I don't know, it's not very easy to see, to appreciate that there are some radiopack bands. The idea is to use the second radiopack band to position the valve with the annulus. Vale, estamos listos. Yo creo que vamos a hacer un cine, por favor. I think this is a good position.
Yes.
Marcaba su RAF 180, por favor.
Quitas el este, ¿vale?
No, luego lo quito.
¿Subo?
Sí, empieza.
Pigtail.
Da igual, no te preocupes. Cincha.
No he podido al tope, ¿eh?
Pone marcapasos.
No he podido al tope, quizá por el
Igual,
pigtail o
no
no sé.
No pasa nada. Vale. Me daba miedo quitar el pigtail porque no se veía bien, ¿sabes? Vale.
No he podido llegar a tope. Yo no sé si es porque ya era el límite suficiente o...
Maybe Dr. Gareto is saying, explícalo si quieres, Guillermo, that the inflation was hard to obtain, the complete inflation was hard to obtain, Guillermo says. I think we have implanted the valve in the right position.
Vale, lo dejamos así.
The patient, I don't remember if they had a wide QRS complex, any...
If it's necessary, we can post-dilate with this balloon with 2 cc more, but we can now we check. I think the position is good. I think no PVL, no.
No, I think there is almost no PVL. I think maybe a very trace place, maybe even related with the wire. If you agree, I know what you that are connected think about the result, but I think that the result seems is very good.
One question from the audience.
Yeah.
That is, the patient had any predictors of coronary occlusion?
No, I don't remember. Silvio has the distance between the aortic annulus and the origin of the. Here we have
the distance of left main is 13.3, and the distance to right coronary is 14. Is height. Both coronaries are height in this case.
In the case, as I told you, and you know, in case we had some predictors of coronary occlusion, there is a discrepancy, an heterogeneity of what is done in every center.
And you must
vamos a sacar un poquito más esto.
You must know that the height of MYVAL is shorter than Sapien 3. Is shorter MYVAL than Sapien 3.
Okay. What we are going to do now is to interchange the wire and to introduce the pigtail. We can see the gradients. Vamos a hacer un cero, que aquí sale un poquito la presión. Vamos a hacer un cero.
Yes.
We are going to do a zero because the pressure, I'm not sure it is.
No, but the radial pressure by anesthetic is 19. Is 90.
Está hecho el cero, ¿verdad?
Espera, no, todavía no. Ahora, último cero. Ahora ya está hecho.
You have to know that you are in the CAD lab we are now. It's a new CAD lab that we have since 1 week ago. So this is one of the first cases we are doing here. So it is an important day for us also.
Te hemos preparado para una inyección de control
vale.
Para ver si
pasamos el pigtail para ver primero el gradiente. Okay. You can see that I don't know if you can see the pressure. It's the systolic pressure is 100. The patient is under conscious sedation. We are going to check the gradients. I wouldn't expect a high gradient. I think everything is going to be okay. ¿Tenemos doble presión? ¿Tenemos doble presión o no?
No está
okay, this is a new. I am going to see what is the pressure of the left ventricle. As I told you, this is a new cath lab we have now. We are. We are going to interchange the pressures. I don't know if we can.
Vamos primero la ortografía para verla antes de sacarlo de ahí.
Sí. Bueno. We have a 140 systolic pressure at the left ventricle. Vamos a hacer un
que lo va a registrar.
Perdón.
Lo va a registrar el
vale, va a registrar.
Pero primero hacemos la ortografía, ¿no? Porque si lo sacamos luego volver a pasar.
Pero para ver el gradiente aquí simultáneo, no podemos ver.
Gradiente simultáneo, pero no tenemos la otra presión.
No tenemos otra presión.
Ya tendrían que montarla y ahora montar esto.
So the second pressure is not mounted, so we are going to change the
¿Lo registran o no lo registran?
The connection. Ven, 140.
I think I got it.
It's been recorded.
Pero antes de sacarlo,
sí.
damos por bueno.
Sí, pero yo creo que vamos a conectar aquí, por si acaso hay que posdilatar. Just in case we have to predilate, to postdilate. Vale. Okay, the pressure at the
is similar.
Is maybe 140 and 130. So I think the peak gradient is 10 millimeters of mercury, more or less. I think the result is very good. We are going to check it again with an injection, contrast injection in a right view.
Espera, todavía no. Ya.
Okay, I think it's nice.
It's zero.
I think there is no PVL. Zero PVL, as Guillermo says. The gradient is, I think, about 10 millimeters of mercury. I think the result is good.
Pues hacer una retirada buena.
Sí, vamos a hacer. Yeah, we are going to see the ventricle while we are retrieving the pigtail from the left ventricle to the aorta. So we are using the MANTA device as the default closure device for TAVI. We have good results, but as everyone, we have some complications as always occur. In this case, Guillermo has used the MANTA has measured, and I think it was at the dip was 3.5.
Yes.
3.5.
Yes.
You are going to see it
The
now
anchor
going here.
will open about 5 centimeters.
Okay, the systolic, the pressure is here, 135, and now, yeah,
No.
maybe between 5 and 10, the gradient, millimeters of mercury, the gradient.
See me, you know.
So I think we have finished the implantation. What we are going to do now is what sometimes is the most difficult part of the procedure, that is to close the artery. It is not needed to use the dilator to retrieve the sheath. What we are going to do now is to interchange by a wire. Sometimes we use the 35 wire, but we like to use an extractive wire to implant the manta, because we had some problems in some patients with a conventional 35 wire.
Vale, sí. Sí, mejor.
No hay preguntas. No. You are very shy, all of you. We have no questions in the chat.
Another important thing, just talk about something related to the procedure, is that we always work with the support of the anesthesiology team. Now here is Dr. Del Campo and Joaquin Vila. And we talked before, but it is very reassuring for us to have them taking care of the patient, and we can focus on the procedure.
Yeah, we are very lucky with the anesthesiology department, because they are the same anesthesiologists that work with patients that are undergoing a cardiac surgery. So they are very experts in doing very important, very complicated cases when we have some complications. And we have the availability of having an anesthesiologist with us almost all the days. So we are very extremely good with them, extremely comfortable with them. So what we are going to do now is to retrieve the sheath. The manta device is prepared, I think.
¿Necesitamos el director o no con
No,
este
no
caso?
me falta.
Espera, chus.
Sí, wait a moment.
No, pues que lo he preparado. No. You can see that this sheath is also expandable sheath. We have
It's 14. It's 14.
Yeah. It is a 14 sheath.
14 sheet.
Yeah. A difference, we told you before, the difference with the Edwards valve is that with the Edwards valve, for example, you need a 16 expandable sheath if you use the 29, but here with the MYVAL, you need always a 14 expandable sheath, even with a 32 valve.
This is the manta introducer to the end. You go back with the dilator. And now, yes, see, quickly with the
We don't like this valve. Sometimes you need to put the wire just in the center of the introducer, because if not, the patient bleeds. Esto no sé si está.
No está bien, sí.
Vale.
This is the other part of the manta device with the collagen of the anchor.
We're going to tell you something. Theoretically, with the manta device, you have the problem that if the manta fails, you don't know what to do. A couple of weeks ago, we had a failure of the manta device. What we did was to retrieve the manta device, but maintaining the wire. With this wire, we implanted 2 angioshield devices, and the patient and the case solved very well.
Now we are going to. I'm looking for the 5 centimeter. Slowly, 9, 8, 7, 6.5. More here. This position. Open the anchor and go back. And push the collagen plaque against the femoral wall.
And now we have the most boring moment of the procedure, because we usually wait for 1 minute, that we all are always counting 1, 2, until 60.
It's very important, the inclination about between 45 degrees, 90 degrees. We need to maintain about 1 minute. The traction is enough because it's in red, the mark. Muy de tiempo.
¿Un minuto ya?
Yo creo que ya vas.
Okay. Now we go back with the blue part. We check if in theory it's okay. Live, please.
No, que se le pega.
Okay. Sorry.
It's okay, ¿no?
El vídeo la guía, ¿no?
Slowly, because it's the stressed wire.
Yeah.
They are retrieving the wire.
We push with the blue part if you want. No.
And we can cut the
You
thread.
cut it? Yeah. Now what we are going to do now is
Check.
To check it. To check with a contrast injection through the contralateral artery. We usually use the wire that we have. We usually use a catheter. In this case, we are going to use a right Justin's right 4 catheter that we have on the table. El catheter 4. The mammary. No problem. Yes, the mammary catheter we have now. We introduce it.
The principal complication of MANTA device is the stenosis. And in some cases, it's necessary to dilate the femoral artery. We will see.
If the result is good, the case we will have finished. So, but the good part is that if the result is not good, we are going to be with you more time.
Vamos a girar un poquito aquí.
Es así, ¿no?
Sí.
Yes.
Contarlo del marcador.
The radio pack marker, you can see the radio pack marker seems to be in the right position, in right. So we expect the result is going to be good. Un test, por favor. Okay.
No, it's very good. The marker is outside the wall. It's outside the wall.
It's perfect.
The marker should to be has to be outside of the wall, so it's a correct position.
It's very good. No bleeding.
What are you going to do with the pacemaker? We always ask to the anesthesiologist.
Inside the patient.
Lo dejamos.
Sí, the anesthesiologist say that we should maintain the pacemaker in the patient, so we usually follow the criteria of the anesthesiologist. So there is no new conduction abnormalities, but the patient had some conduction abnormalities before the procedure, so we have decided to maintain
right block.
Yeah. The rate of pacemaker with this valve is similar to the Sapien. In fact, there is some study, of course, non-randomized study, that showed a slightly lower rate of pacemaker with this valve in comparison with the Sapien. The explanation of the authors was that having intermediate sizes, you can use the most exact size for each patient, and this theoretically could reduce the incidence of pacemaker and also the incidence of annulus rupture. We don't know, but this is a theory, but it could be.
¿Cerramos con un angiosil o...?
Angiosil del 8, sí. ¿Qué hacemos ahora?
Okay, if there is no more questions, that I think there is no one, we're going to finish the case. I want to thank again all the people who worked in the case, also the people from Stream, Phyllis, MYVAL,
the audiovisual staff from the hospital that make possible to be here, and also the anesthesiology team, the guys who work in the case. So we are going to close the other femoral artery and close the connection just to see you in a couple of hours doing a coronary procedure. Thank you.
Thank you very much. Thank you.
Sí, yo creo que sí. O lo que te diga Guillermo.
No.